Welcome to the Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is SeamlessMD CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Dr. Jennifer Goldman. Dr. Goldman is Vice President of Information Technology and Digital and Chief Medical Information Officer at Memorial Healthcare System in Florida. Dr. Goldman, Jennifer, welcome to the show.
Thank you for the opportunity. Great to meet you both.
Absolutely. We are so thrilled to have you on today. You've had such an expansive career dedicated to innovation and healthcare transformation that's really centered around the holistic health of not only your patients, but all the populations and communities of patients that you serve. I heard you share once in the past some career advice that you should do something that you love. And so I'm really curious. I want to start the conversation there. Why was that medicine or primary care for you?
Sure. I wanted to be a doctor since I was 2 years old, and I credit that really to growing up in a family that was very centered on service, community service, and helping those around me, and really had a nice upbringing in that way, and thought that medicine would be a great way to achieve that. And I also really loved learning as much as I could about other cultures and how everyone interpreted medicine and health in general. And so when I went off to college, I majored in medical anthropology, did a minor in organic chemistry, and so got my prerequisites for medicine, but always was focused on a holistic approach to really taking care of the health of the community. It's actually why I also chose osteopathic medicine as my medical career route, because of the philosophy of whole person approach to care. And my career choice in primary care really was kind of evolved naturally from there. And it's given me the ability to provide care to patients of all ages, as well as to really be that continuous relationship-focused care point for people in our community. So it's been very fulfilling over the last 17 years to do primary care, and now to have the opportunity to lead at a different level and really help with efficiency and access and experience for patients and healthcare providers, physicians, and APPs and nurses across our system has been gratifying.
Amazing. So we have to ask, we noticed that you did your undergrad at McGill. Are you Canadian? Because Alan and I are Canadian, and it's okay if you're not, but we were curious.
I love Canada. I am not Canadian. I am from Rhode Island, and I had some very good friends growing up who were Canadian. And so when it came time to apply for schools, I branched out and thought about going somewhere else, and thought about McGill, which is just a phenomenal school. And when I went to visit Montreal, really fell in love with the city and the people. Not so much the cold, but the city and the people, and really loved it, and thought hard about leaving Canada to come back to the US for medical training.
Well, for today's episode, we shall have you as an honorary Canadian.
Aw,
so welcome. So, 10 years ago, primary care was all the rage in Canada, and family doctors were promoting it, and a lot of folks were entering it during residency. The last few years, it's been on a major decline in terms of interest in family medicine, particularly in Canada. And we look at some of the residency application numbers, they've fallen too, and a lot more folks are going into other specialties now. I'm kind of curious, are you seeing that as well lately, south of the border? Are you seeing that maybe specifically for osteopathic medicine, or is it? I'm just curious what you're seeing among trainees and all that.
Unfortunately, and it's been well documented across the board, there's a decline in interest in primary care, and there has been for quite some time. And it's sad, and there are multiple factors that go into that. Payment certainly could be part of that. It's expensive to get a medical education. It's expensive to pay that education off. And primary care certainly doesn't get reimbursed as well as other specialties. That tends to stem from our healthcare system's focus on procedural-based specialties and reimbursement based on that, as opposed to reimbursement based on cognitive work. The goal in the United States is for value-based care to really change the face of not only health in the US, but reimbursement and ability for people to go into primary care as a viable career. I think we haven't seen that pan out as yet, and it hasn't translated into more applicants seeking primary care as yet.
Today's episode is brought to you by DeepScribe, AI clinical documentation that physicians and health systems love, documenting specialty and complex care with ease and precision. Josh, have you heard all the buzz around ambient AI and virtual scribes?
Definitely. Clinicians are spending hours a day on documentation, so improving their day-to-day and reducing burnout is huge right now. You and I have seen quite a few product demos for ambient this year, but I have to say, DeepScribe was one of the most impressive.
Well, Josh, you trained as a clinician. What stood out to you most about DeepScribe?
Well, using AI to transcribe and summarize the clinician-patient conversation is honestly table stakes right now. But a big challenge for CMIOs and CIOs is driving actual clinician adoption. So what really impressed me about DeepScribe is how well it can be customized to different specialties and workflows with dozens of templates as starting points. That would be critical to me as a clinician because I just don't have time to build templates from scratch.
So true. For me, I was particularly impressed by the auditable notes. You can highlight any part of a note, and then DeepScribe shows you exactly where in the transcript the note was generated from, so you can find that evidence right away. That builds trust.
Oh, exactly. Being able to confirm that something wasn't hallucinated is so important for clinician trust and safety.
Yeah, that same attention to detail that led to really high clinician adoption is also resulting with clinicians saving up to 75% of documentation time.
Wow, that's incredible. But how is DeepScribe's accuracy with specialty care or complex cases?
That's the best part. DeepScribe's proprietary LLM, Heal AI, is trained on over 3 million patient conversations. It's then further tuned by specialty and subspecialty cases, making it way more accurate than GPT-4-based solutions. Pair that accuracy with DeepScribe's customization studio to personalize the experience for different clinician preferences and workflows, and it becomes incredibly flexible.
Alan, speaking of flexibility, I could use some yoga myself. Flexibility is key when it comes to working with health systems with so many moving parts. DeepScribe sounds fantastic. Where can health systems learn more?
About your yoga? I don't think they want to. But about DeepScribe, check out deepscribe.ai. That's deepscribe.ai to learn more.
Well, one thing we have seen on the rise is definitely the interest in informatics and technology in healthcare. You clearly went down that path at some point. What was your story around that transition?
So I have a non-traditional background for sure to be in informatics. My background undergrad is in anthropology and then went to medical school and did residency and kind of went straight on in that path. However, when I started working at the healthcare system that I'm working at now, about 10 years ago, I was promoted to the chief of primary care. And when I was promoted to that role, not just from a management perspective, but also from really a transformational leadership perspective, it was so important for me to achieve buy-in for all of the things that we were trying to do, increase access for our patients, improve health of the community, do well in value-based care. And there's a lot that goes into doing well in value-based care, coding and documentation. And there was an article that came out that I'm sure you're aware of that said it would take 26.4 some odd hours in the day for a primary care physician to manage a panel of patients and really do all of the acute care and preventative care needs for that patient population. So the workload of primary care was increasing and the responsibilities on the shoulder of primary care were increasing. And I was in this position to really transform our healthcare system's primary care. And the only way that I saw that we could do that was really to optimize how we interacted with the electronic health record, how we could use the EHR to help us to do our job, how we could build a better product so that our doctors would be able to focus on patient care and that all of the preventative needs that a patient had, all of the social determinants of health that somebody came in with, that we would be able to automate in a form the capture of those diagnoses, the ordering of those tests, and really make it so that it was an equitable form of practicing primary care where the EHR could use the information that we had and really pend all of that to the providers. And so because I had this vision of how we could make primary care work and take on all of this value-based care transformation without having all of our doctors leave because of the increased work on everyone's shoulders, I got really involved with our IT team, and we have some phenomenal ambulatory IT analysts, and I worked with them over the years to really custom build what we use now are express lanes in primary care to pend all of these preventative care needs of somebody, associate automatically diagnoses, pull in Z codes for social determinants of health, and do all of that on a foundation that really standardized how we document in primary care and how we interact with the problem list. And it was that ability to, I really at that time didn't know the term architect in IT, but that's really the role that I was serving. I had the clinical workflow down and knew where we needed to go and needed to speak the language to somebody in IT who could help us to build that. And it was extremely successful from a value-based care standpoint with millions of dollars, 25 plus millions of dollars insured savings back to the healthcare system. We're the third largest public healthcare system in the country. We serve everybody. And so being able to bring back revenue to the bottom line to reinvest in the community was really important. And then I really became very interested in, well, how could we leverage that skill of really change architecture? How do you optimize the EHR for more people across the system? How could we do that across the board? And so that's how I came into becoming a physician builder in the EHR and then really going into this role as well.
I love that. There's so many directions we can take this conversation. Social determinants of health is obviously a huge part of your story so far and the work that you're doing today. Also EHR optimizations. We'll get to that in a bit. I just have one question that I was curious about. Given today's economic climate, over the past couple of years, the focus for health systems by and large has been tackling workforce shortages and increasing revenue to get out of the red. Like you alluded to, you're a public health system. Bringing in revenues is going to optimize every other channel that you have at your disposal. So I'm curious, as a digital health leader today, how do you balance those priorities that you're working to improve patient outcomes, but then that could also be at odds with some of the other competing priorities for the system? What's your take on that? How are you balancing those priorities?
So one of the things about my background that may help to contribute to that is that I've always been, for the past 17 years, I've practiced in community medicine settings where revenue was scarce and we needed to innovate in order to excel in our mission so that no margin, no mission really hits home. And in digital health, we need to do similar. We need to bring in new technologies, but each of those technologies has to have a benefit to the bottom line. And we also have to avoid going down the road of the new and shiny if there's no operational impact or if you can't operationalize the value of that technology. So trying to be discerning when looking at all of the new options that are available for digital health. And really, I still see patients in my new role, and that keeps me grounded in truly trying to understand every single day what our mission is. And if the new technology is not going to improve how we take care of patients, how patients can access our system, or how healthcare providers can continue to practice medicine in this climate, then we shouldn't be investing in it.
One of the things that you've been a champion on, as Alan mentioned, has been around weaving social determinants of health into the way you do digital health and informatics. Maybe we could double click on that. So what would be, an example of how that looks in practice for you at Memorial? Like, what's a day in the life of using social determinants of health actually in the EHR and the technology workflow?
All of us, we have our own social determinants of health. So this morning, I got up early. I went for a run. I came back and made breakfast for my kids. My 17-year-old then drove the kids to school, and my husband is making dinner for the family when he comes home from work. My social determinants of health in that setting are that I have a safe neighborhood to go for a run and do exercise and improve my health. And I have a roof over my head. I have a community and a family that provide me love and respect and warmth. And I have enough food on the table to be able to provide for the needs of my growing family. For patients in our healthcare system, sometimes their social lives, their lives don't look like that. And so for a day in the life of somebody coming into our healthcare system, where we prioritize learning about what those social determinants of health are, that can look like somebody coming into our primary care center and either answering questions during e-check-in about, do they have enough food on the table? Has there been a time where they couldn't afford rent and were facing homelessness? Do they have transportation to their next appointment? Do they have community? Do they feel lonely? And questions such as that. Or if they are not comfortable using digital technology to do that, then when they come in and are roomed in the office, then the medical assistant will ask them those questions. From the physician standpoint, when we then walk in the room, we have an express lane that pops up that drives our note template, that drives all of the preventative orders that we'll need. So for somebody to have a mammogram done for breast cancer screening or colon cancer screening done, all of those orders are already populated and associated with a diagnosis. And what we add in this kind of tech-enabled social determinants of health screening was we put those social determinants of health that the patient screened positive for, meaning that there was an issue with food insecurity or there was an issue with housing. And we put it front and center in that express lane, but we didn't make it a disruptive alert. So we didn't make it a BPA or a pop-up. We put it in line in the express lane, already associated with a diagnosis and already with a referral to our social determinants of health hub that can reach out to patients and really offer guidance with assistance in housing, for example. We also give patients who do screen positive information about 211 Broward, which is an organization in our community that provides information on healthy food and how to get access to food, on transportation. And we have a patient-centered medical home with health coaches and social workers that can help to reach out to patients that need. And so for the patient in that situation, what we've found is that our patients are appreciative of being asked these questions. They're appreciative because times are tough for everybody, and that's really how we educate our staff in asking these questions. Times are difficult for everybody, and we want to know if you're struggling with issues that could impact your physical health or your emotional health and well-being. And so when we ask those, it shows that we care, which of course we do. But from a workflow optimization standpoint, it was really important for me to have that workflow not disrupt the visit with the primary care physician, because oftentimes there is only a limited amount of time and there are many other conditions to discuss during that visit. So having the ability to automate the diagnoses and the linkage to care can provide that holistic experience for a patient, but not, I hate to use this word, but not derail the visit for the primary care doctor where they feel like they're running behind for all other visits because they have to then think about how to provide linkage to care. And then if that same patient receives care in the inpatient setting of our hospital, then all of our patients are screened in the inpatient setting as well. And our inpatient clinicians can see that somebody had screened positive for this previously. So perhaps that will impact discharge planning, and they can start with discharge planning earlier if they know that somebody is unhoused or that somebody needs food, because we know these social determinants of health can impact readmission to the hospital or bouncing back to the emergency room.
I've seen studies in the past where when information was collected electronically or digitally, especially sensitive information, patients were sometimes more honest because they were less embarrassed, sending it in electronically versus having to tell their provider face-to-face about sensitive information. I know you've done some work in the past, I think, using MyChart to collect some of this information on social determinants from patients. I was curious if you've noticed that at all, where if they were doing it electronically, maybe you're able to actually surface it more often. Love to know if you've got a sense of that at all.
It really depends because technology use and adoption can also be a social determinant of health, right? And so not being able to navigate your way through MyChart is a serious issue. And we have many people who've signed up for MyChart, but they don't necessarily know how to navigate it, and they don't necessarily feel comfortable navigating that and answering those questions in advance. And so what we find is that for those members of our community who really are truly suffering from some of the social determinants of health that we know will lead them to become sicker over their lifetime, that those patients in need are also more likely to have difficulty using the technology or even have the technology in the first place. So we found varying levels of adoption, and that's why I think it's so important to take a personalized approach. If someone comes in and they can't fill this out on MyChart, then they don't fill it out on MyChart, but they get asked those same questions. And it's also important too, when we put that documentation in front of the physician, who oftentimes the patients have had relationships with longitudinally, then that physician who they're comfortable with, the patient may then say, oh, I didn't want to answer that question when the medical assistant asked me, but I'm really struggling. And so sometimes it's really relationship focused. And I have to say our staff have done a phenomenal job, but we also do a very good job of hiring staff that are from the communities that our patients are from, and oftentimes have personal experience with social determinants of health or difficult upbringing or social issues that are impacting their own health. And so they know how difficult it is out there, and our patients are more comfortable, I think, answering those questions when they know that.
When I think about incorporating social determinants into care, I totally get how from a primary care setting, especially as you mentioned, being in a value-based care kind of setting, there's maybe some natural incentives to spend more time on social determinants because that would impact the whole population health initiative. When I think about maybe on the acute care side or some other specialists where I don't always know if they're maybe trained or educated or incentivized to care about social determinants, I'm kind of curious how you've navigated bringing social determinants and technology into non-primary care settings. Has that been a challenge? And if so, how have you maybe navigated that?
About a year ago, I was asked to do a lecture for our general surgery residents on social determinants of health and the importance of surgeons really digging into the social issues that their patients are coming in with. And there's a lot of data out there from surgical societies showing that patients who have a variety of social determinants of health, such as being unhoused or not having enough food or not having transportation, have worse outcomes when it comes to post-op recovery. And every surgeon cares about their metrics. Every surgeon cares about the person that they're operating on. And where we are in medicine today, it's not enough to do a phenomenal job on the surgery itself. Because if somebody comes back to the hospital with an infected wound because they don't have a place to live when you discharge them home, then that goes on your scorecard. And beyond that, that's that person in front of you with a family and a community that they now can't go back to because they're stuck in the hospital. And so I think bringing it home to the individual specialties is important, and really understanding this is not the purview of primary care only. This is the purview of all of us in healthcare, especially in the United States, where social services that are provided and healthcare itself tends to not always be a right, but rather a privilege. It's extremely important for all of us to be engaged in this part of keeping our patients healthy.
So a couple of things that I noticed there. One is it's definitely not a one-size-fits-all approach. And two is the frequency of when you're collecting this information and the relationships between different stakeholders and the patient. It all makes so much sense. One piece, Jennifer, that I wanted to double click on is the hub that you were talking about, because it's so common for social determinants of health to just lead to a pamphlet being given to a patient, and here's, a couple resources for you, go check it out on your own. But therein lies the problem. And so I'm really curious to learn a little bit more about this hub, and how did that idea come to fruition, and what's so special about the hub?
We developed the social determinants of health hub at Memorial Healthcare System for exactly that reason, because it's not enough to give a flyer or a pamphlet, especially for issues such as homelessness. It's not enough, and linkage to services often has to take a very personalized approach, because every person has their own reason why they are in the predicament that they are in, and a one-size-fits-all approach to solving that is not enough. And so this was a multi-team collaboration from our chief diversity officer to our chief of population health to our primary care leadership and our community services division, where everybody really came together and stood up this hub. That's, I think, has been key to our healthcare providers feeling comfortable asking these questions, and for teams feeling comfortable asking these questions, because they know that patients are going to get the support that they need, and they're not just asking them to collect data. And I think that can be an issue in healthcare sometimes, where there's a new metric and we meet the metric by collecting data and documenting that data, but what are we actually doing to solve the problem? So it was our attempt at solving the problem. And it's the first iteration, and I'll be honest that there's probably going to be an SDoH Hub 2.0 and 3.0 as we navigate this for more and more patients who need services. But we're proud of the collaborative approach that we took, and we've heard really great feedback from our patients and our community. And then the last thing I'll say is that being a public healthcare system means that by default, you need to collaborate with community organizations out there. In fact, as a public healthcare system, you are an anchor institution in the community, and you have a responsibility. You're going to be there for a very long time. And so you have a responsibility to understand and interact with the community services around you and partner in providing the best care to the community. And we have some phenomenal individuals at Memorial that do this so well, and over the years have established fantastic relationships with the community that we serve, so that we're able to, our caseworkers or our social workers are able to make a phone call to a food bank that we partner with. And not only is it a sort of nameless, faceless food bank for somebody to then call, but it's a very personalized program where oftentimes food can actually be delivered to that person's home, or they'll arrange for the person to drive by and collect the food. And if they don't have a car, have somebody assist them with that. So a personalized approach, but that's built on years, really decades of relationship building with the community.
Yeah, I love that. I feel like in the past, there may have been this paradigm that, hey, if I'm a medical professional, my toolkit is only, what I was trained on to do as a physician with my stethoscope and surgery or what else you might do. But now we know healthcare outcomes have a lot of holistic, contributing factors to it. And so in many ways, it's realizing that, hey, actually, if I'm trying to move the health outcome of the patient, my toolkit is now much bigger than just my stethoscope. I know I'm oversimplifying it, but I know you get what I mean. I'm glad your team is there. I know a lot of folks, I don't think still are there yet. I've met a lot of folks who think to themselves, well, social determinants, that's public health's job. That's the government's job. It's not the health system's job. But I think as you're clearly explaining to us, it's everyone's job if you care about the ultimate health outcome. I love that.
Today's episode is brought to you by SeamlessMD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what SeamlessMD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. SeamlessMD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50 plus out-of-the-box care plans available today on SeamlessMD. Go to www.seamless.md. That's www.seamless.md to learn more.
It is a digital podcast, so unfortunately, we have to mention the 2 letters of AI at some point on this podcast. So we did want to ask you, what do you believe is kind of the low-hanging, high ROI use case for AI in your healthcare system now? And then maybe what are some use cases that you feel like are just overhyped, maybe too much buzz right now?
Oh, there's so many. So I think that ambient technology for, crafting notes in the background while physicians are communicating with patients and there's a dialogue there has tremendous potential. We're rolling out a solution for that now, and we've seen tremendous success from some of the physicians that we've rolled this out with. On the other hand, to take a balanced approach, feel like as technology evolves, it still is a tool and it's not the be-all end-all for healthcare. And there are going to be some physicians that don't feel like ambient technology actually helps them with their workflow at all. And then there are going to be others where it is an absolute game changer. So, and I'll say from an ROI standpoint, physician retention alone could really impact the ROI for digital technology such as ambient listening if it's the right use case. For other use cases of AI, I think there are so many use cases for generative AI for message generation back to patients or chart summarization. And really the list goes on. Bidirectional texting with patients. There's so many things that we can do with AI. But I think that we do need to take a bit of a tempered approach because there's liability for that with healthcare physicians as well, providers, specifically physicians. And in the United States, I know you guys are Canadian, but in the United States, liability is a big deal. There are a lot of lawyers in the US and a lot of instances of, malpractice suits where physicians are using information that's given to them and making decisions based on that. And so you can see that if there's hallucinations with AI in medicine and physicians are not triple checking the generative message that went back to the patient, then there could be issues with that. But we're excited to partner with our EHR and with other vendors to implement AI, but cautiously is what I'll say.
Makes total sense. Looking at some of the data that's come up publicly around ambient, I think it was, I don't want to butcher this, but I think it was Kaiser that came out with some of their data from last year from their initial kind of rollout of ambient. And I think they said, what was that? Was it 6 to 8 weeks? Maybe 20 to 30% of clinicians were actually adopting ambient or something like that. I'll have to look up the actual data. I don't want to get it totally wrong, but it wasn't the majority. And now to your point earlier about patient interventions, it can't be one size fits all. Even patients need different interventions. I'm kind of curious, when you think about success of something like ambient, is there a certain percentage where you're like, if 50% of clinicians actually use ambient, that's good because you don't expect everyone to use it, or are you aiming for something higher for it to be, worthwhile to deploy?
So I really think that any tool that we can deploy that makes the lives of a clinician just that much better in terms of their day-to-day is fantastic. And I don't really have a benchmark in 20%, 30%, 75%, let's say, adoption of this tool, because I see it as a tool. And we have certain divisions where their notes are so templated, they feel they've optimized their experience with the EHR enough that ambient technology would really help them to avoid typing the HPI or dictating the HPI, but the rest of the note is done because of the templated approach that they use. And I think you're going to find that as more physician informaticists come out and are helping to build these tools in the EHR anyway. And so really our strategy is providing ambient as a tool for the clinicians who are burned out, who are using scribes right now, real live scribes right now, and how we can help to replace that workflow. And then for others that are super users and interested in efficiency and technology and haven't found that with their current methodology, I don't have a benchmark. And I think that's the other thing about AI in medicine is that ultimately that medical decision making is more than just the conversation with the person in front of you. It's more than that patient encounter. It takes so much when it comes to reviewing the documentation in the chart, thinking about what are the best possible treatments for this condition, talking to somebody about actually implementing those treatments and helping to see if do they have issues with transportation so that it will be difficult for them to actually stay on that treatment if it's a specific regimen, or do they have issues with housing where they can't actually take pills 3 times a day. And so that interaction with patients is so important that the documentation piece is secondary, but the time that it takes and the mental energy that it takes is the same. And so I think that could be why, and I believe it was Stanford that recently published their experience with, I think, generative AI for messaging back to patients and how it increased satisfaction but didn't save time. And I think ultimately that's what we're going to find across the board, because clinicians still need to review what's in front of them and they need to collate what they're reading with all of the other inputs from the chart and from the person in front of them. So we'll see. It's a fun ride though.
Yeah, and it sounds like, even if you don't save time, to your point, if you're seeing an improvement in clinician well-being, in peace of mind, that's still an ROI that matters at this time.
100%. And that's why I hesitate to tie it back to increased encounters. I hesitate. That may happen, and that's great because we need to provide more access to our patients. But if we can save somebody from leaving the profession, which is what so many are doing, or if we can encourage somebody to go into primary care, which is seen as such hard work with a not similar reimbursement, then that would be a win.
One of the other really unique things about that Stanford study, I actually just pulled up here to refresh myself, was they saw very different adoption rates between different types of stakeholders. So in primary care, they had 44% usage among pharmacists, but only 11% usage by primary care nurses. And so for some reason, it was loved way more by pharmacists. I'm not sure if you have a hypothesis as to why, but I found that very fascinating. And it goes back to, well, maybe it's not for everyone or every specialty or even every stakeholder in a single specialty. That I do not know how to explain. I'm curious if you have a take on that, but I thought that was really interesting.
I think it's really interesting too. I think it has to do with the pools that they've set up probably for messaging to go back to anyway, the users that are actually the ones that are interacting the most. And then, with pharmacists, and I love pharmacists. We've integrated pharmacists in our workflow across the healthcare system for medication management and really longitudinal relationships with patients with certain chronic diseases like diabetes, for example, that they and this is conjecture here, but I'm thinking that the skill that our pharmacists have in medication management, they know where they want to go right away. They see that A1C, they see the med list, they know exactly what to do, which medicine to add, which one to increase. They know the guidelines, they know the adverse effects of medicines, and they know that all really well. And so maybe they loved the fact that the AI generated the rest of the stuff for them so that they could just populate what they are passionate about, which is changing the medication. But that is conjecture. I've not spoken with any of my pharmacy friends on that and could be completely off base, but it is really interesting to hear the data.
Definitely.
Absolutely. So, Jennifer, I wanted to ask you as well. You brought up at the top of the podcast that you've been working on EHR optimizations to impact clinician well-being. Obviously, you are an Epic shop. I'm curious what would be a relatively small optimization that you found to have the most profound impact on your patients or your providers, or hopefully both?
I'm lucky in that we have quite a few. We have a phenomenal team in IT here. Our analysts are amazing, and they've done so many impactful projects over the years for our teams. We recently rolled out some decision support tools and an AVS print block for to encourage medication reconciliation at discharge. And we're able to increase our percentage of medication reconciliation at discharge from 82% up to 98.8% system-wide, and holding for the past 8 months. And it's because of the tools that we implemented, but it's also because of significant change management and really going across our 6 hospitals and engaging with the medical and the nursing leadership to talk about how important that is, and then tying it to metrics at the organization level to make sure that really there's a burning platform to make that change. And then as an outpatient corollary to that, I truly think that Express Lanes, as we talked about before, in their ability to, even with a non-problem focused visit, but a general visit in primary care, to be able to key up the preventative measures, to be able to key up the social determinants of health and diagnoses, as well as key up a documentation template, have reduced so many clicks that they've been and have really led to tremendous amount of ROI. That's another relatively simple, it's not simple, and our amazing ambulatory analysts will not think it's simple at all. There are tons of CER rules behind the scenes that make all of that work, but it is that kind of tweak to the system. And then finally, I'll say in our governance across the board, where we've set up governance for decision support that we've implemented across the system, we've been able to eliminate over 800,000 clicks and more than 19 hours of clicking per day for our clinicians' healthcare system wide. And in so doing, we see that they're clicking on the ones that we have remaining, the very important ones that we have remaining, at a higher rate. And so things like that, optimizing the system, getting rid of stupid stuff, as I know it's been called over the years, has been a really important strategy for us on physician wellness and wellness informatics.
You know what's funny? I just realized the other day that getting rid of stupid stuff, the acronym is GROSS. I didn't realize that before. That's pretty funny. You brought up change management, and I was curious, is there a certain change management tactic or best practice that you really love that you just will use over and over again because it works really well?
Pre-meetings are so important for change management, meaning having those meetings with the key stakeholders, truly understanding where they're coming from, what their workflow is, going in person as much as possible for those meetings, rounding, and really being there at side by side with the anesthesiologist, side by side with the radiologist, with any clinician, to really understand their workflow, so that as we're introducing something new, then you have the street credibility, as well as you know where people are going to vote before the actual meeting occurs. Doing that as much as possible, when possible, has really been key to to change management. There's so many other strategies, and John Cotter's book, Leading Change, is kind of the Bible here for that. And there are others as well, but there's a process to leading change. And what I've found over the years is in projects that, let's say, didn't work out the way that I wanted and certainly weren't adopted immediately, when I go back, I realize, oh, I didn't do that step. And so it's important, I think, to keep in mind that's a learned skill as well, just like practicing medicine is. And the more we can learn how to maneuver and how to be transformative, the better outcomes we can have.
Well, you mentioned the importance of being there in person for change management. I'm curious, over the last few years, with the rise of Zoom and virtual collaboration, have you seen Zoom make change management worse in any way?
I think that if you're trying to get a decision on a call and you've not had any pre-meetings and that call is solely virtual, then yes, it can make it much harder than those in-person meetings where you can see everybody's facial expressions. So many times, Zoom is one thing, but Zoom without cameras on, or WebEx or Teams without cameras on, is a whole other thing. And sometimes you feel like you're just speaking to thin air and there's not one person actually receiving the information or actually wanting to engage in a dialogue with you. So yes, I think that it can hinder success there. And that's why, going back to those principles of change management, going in person, really being there to understand the workflow and making it a priority to take interest, which is what we do. We are interested in the end user's workflow. If we're not, then no matter what we implement, it's not going to be successful. I think combining those strategies is important. And then you can have your Zoom meeting, or then you can have, your virtual conversation, because again, you've already been there and people know that you're engaged and they understand that you're trying to do the best that you can with the tools that you have.
It kind of reminds me how, for folks that I know really well, that I've had face-to-face meetings with, I'm totally fine, having an audio-only call with. But when you're meeting someone for the first time, if you can do it in person, it makes such a huge difference to establish that rapport first. That makes a ton of sense.
Absolutely.
Yep. So Jennifer, just being mindful of your time, I had one last question before we flip over to the Fast Five. I noticed almost 10 years ago, you and your husband, who I believe is also a physician at MHS, started a nonprofit dedicated to training healthcare professionals in Haiti on emergency response, best practice, practical training, and partnership. I have to imagine that this brings such a unique dynamic and insights to both your professional and personal lives. So I'm curious, how has Primary Care Haiti influenced your approach to healthcare innovation and community engagement, both locally and abroad?
So my husband is Haitian. I met him in medical school. He's an emergency room physician at our system. And I speak Creole and Spanish through working in South Florida and the patient population that I serve. And we started going to Haiti over 20 years ago. First, visiting family and really engaging as medical students in hospitals in Haiti. And then when I started my role in primary care at Memorial, I met a really influential person who is a fellow primary care physician here, Dr. Moise, who retired to Haiti, but retired is in quotes because she continues to work nonstop. And it was with her partnership that we started Primary Care Haiti and are able to, even with the dire situation in Haiti, both on the ground with violence and politically, as well as all of the social issues, we feel like we're continuing to make a difference because we have this train the trainer model where we've educated already hundreds of physicians and nurses and have a partnership with them to continue that education and training. And in fact, as we speak, I was getting texts this morning on WhatsApp from Dr. Moise about a training that they just did in the north of the country where, again, hundreds of nurses and doctors attended despite all of the issues in the country. And I think that how it influences my practice here is really a continuum. In South Florida, there have been times in my career at my prior healthcare system where more than 85% of my patients were Haitian, and they have significant ties back to the island. And if things were improved, they would love to go back and give back. And so the ability to give to that community here as well as abroad has been extremely fulfilling and a great reminder about why we're all here in the first place and how our circumstances, how we live, how we grew up, shouldn't influence what we're able to achieve in life. And so the ability to continue to give back in that way just fills my soul.
And how everything is so connected as well. That's really awesome. So like I said, let's flip over to the Fast 5 lightning round. This is just 5 rapid fire questions for you. The first question we have is, what is your favorite book or book you've gifted the most?
So I have 2 books for that one. Nudge by Thaler and Sunstein. I love that book. Choice architecture, you may have heard me mention earlier, is I think the foundation for clinical informatics. And so I think that learning how to smooth the path and nudge people in a certain direction is really crucial to change management. So from a business perspective, I love to gift that book. And then from just a fun but also medical perspective, The Covenant of Water by Abraham Verghese is fantastic. He's a professor of medicine at Stanford and wrote this phenomenal book that weaves so many stories and then ends with a really interesting medical diagnosis. So love that book.
Wow, very cool. Second question, who is a person either dead or alive who you'd love to meet?
I would have loved to have met Paul Farmer. Paul Farmer started Partners in Health and he passed away tragically a couple years ago. And I was very close to meeting him with our work in Haiti. And when I was studying anthropology in college, I actually came across one of his books, Mountains Beyond Mountains by Tracy Kidder, and the life and work of Paul Farmer. And so I would have loved to communicate with him and just thank him for all of the work that he's done to advance healthcare for everybody in some of the poorest countries in the world.
Okay. Yeah. Love it. Number 3, would you rather have super strength, super speed, or the ability to read people's minds?
Super strength, more because I really love surprising people. And at 4'11" and just over 100 pounds, having the ability to lift a car or a building would just be fantastic.
I love the upper bounds, like a building as well as a car. That's so awesome. I love it. Question 4, what is something in healthcare you believe that others might find insane?
There are so many, but the idea that we take care of everybody that walks into our facilities and that care is not contingent on payment here is something that just doesn't cross well into other business models.
Yeah, very true. Last question, if you could travel back in time to any event or moment, what would it be and why?
I would love to be there at Ellis Island when my grandparents and great-grandparents immigrated to the U.S. I think it's a really important reminder for all of us in the U.S. that we all come from somewhere else. And it's important to continue to remember that as we take care of newly arriving immigrants to our country, or if we choose to live somewhere else during the course of our lives. I think it's really important to understand where we came from and how it all started.
Very true. What a great message to end with. Thank you, Jennifer. Thank you so much for joining us today and really sharing some of your wisdom with us and our audience. That's a wrap for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter at SeamlessMD. If you like the podcast and you want to learn more, visit www.seamless.md. Dr. Goldman, again, thank you so much.
Thank you so much, guys. This was fun.